Good morning everyone. Today's my topic of presentation is anatomy and physiology of the macula. Embryology and development of macula. Macula develops from optic curve. The inner wall forms the neurosensory retina and the outer wall forms the retinal pigment. Outer wall forms the retinal pig. Outer wall forms the retinal pigment epithelium. Development of macula lag behind rest of the retina and considerable changes occur after birth. Macula is barely functional at birth. Histological and functional maturity occur by 4 years. Functional maturity. Visual fixation is present at birth and is well developed by 2 months. Visual following is well developed by 3 months. Differentiation of fovea is completed by 4 months and characteristic foveal reflex is present on ophthalmoscope. This is the optic cup from which the macula develops. Macula lutea area centralis or yellow spot or central retina. It is 5.5 mm in diameter, centered 4.0 mm temporal and 0.8 mm inferior to the center of the optic disc. Area deeper red than the rest of the fundus at the posterior pole, temporal to the optic disc between the temporal vascular arcade. It is 3.5 disc diopters or 18 degrees of the visual angle. Histologically, macula is a region with more than one layer of ganglion nuclei. It subserves central 15 to 20 degrees of visual field. It can be divisible into foveola, fovea, perifoveal region and the parafoveal region. This is the image of the normal fundus. This is the optic disc. This is the macula, which is deeper red than the rest of the fundus. This is the macula, which is divisible into umbo, foveola, fovea, parafoveal macula and the perifoveal macula. Fovea centralis, it is central 1.5 mm diameter, 1 disc diopters or 5 degree of visual angle. All layers of retina are present. It contains xanthophyll carotenoid pigments, lutein and zeaxanthin responsible for yellow color of the fundus. Specific anatomic configuration of the fovea. Densest concentration of the cones, 1-to-1 photoreceptor ganglion cell relationship. Cones are more elongated and slender. Absence of rods at the foveola. Retinal pigment cells are taller, thinner and deeper pigmented. Presence of xanthophyll pigment. This dense concentration of cones, taller retinal pigment epithelial cells and presence of xanthophyll pigments is responsible for the darker color of the fovea centralis. This is the microscopic image of the foveola. This fovea, these are the layers: inner limiting membrane, nerve fiber layer, ganglion cell layer, inner plexiform and inner nuclear layer, retinal capillaries, Henle layer, outer nuclear layer, elongated cones, pigment epithelium and the choriocapillaries. This is the histological image of the foveola. Foveola, it is 0.3 mm depression in the central floor of the fovea, 0.3 to 0.4 disc diameter, most sensitive part of the retina. It is devoid of ganglion cells and inner nuclear layer. Umbo, it is tiny depression in the center of the foveola. It corresponds to foveal reflex. Parafoveal area, it is 0.5 mm wide ring surrounding the fovea. Perifoveal area, it is 1.5 mm wide ring surrounding the parafoveal area. Foveal avascular zone, it is located inside the fovea but outside the foveola. It is 0.4 to 0.6 mm in diameter. This is the visual field chart. In it, it occupies 1.5 degrees foveola, fovea 7 degrees, macula 18 degrees. 0.35 mm diameter, 1.5 mm diameter and 5 mm diameter. This image is a summary of the above theory. Neuroepithelium layer, it contains photoreceptors, rods and cones. There are about 120 million rods and 6.5 million cones. Rods, it helps in scotopic vision and contain rhodopsin pigment. Rods are absent in the fovea. Cones, they contain a photosensitive substance, photopsin, primarily responsible for discriminatory central vision and the color vision. Highest density in the fovea. Interphotoreceptor matrix, space between the photoreceptor, outer membrane and retinal pigment epithelium. It contains glycosamine glycans. Interphotoreceptor binding protein. It accounts for 70% of soluble proteins in the interphotoreceptor matrix. It is produced by the photoreceptors, mainly cones. Blood supply of the macula. It is supplied by small twig of superior and inferior temporal branches of central retinal artery, sometimes by the cilioretinal artery. This is the optic disc. This is the macula. From this we will have papillomacular bundles. These papillomacular bundles are resistant to glaucoma disease. It means they are the last to be affected in case of glaucoma. Applied anatomy. Foveal reflex. Intensely bright spot of light visible ophthalmoscopically due to reflection from the walls of foveal depression. Loss of foveal reflex may be an early sign of damage. Cister macular edema appears stellate in macula and honeycomb appearance outside the macula. It is because outer plexiform layer in macula is oblique. Cilioretinal artery. It is paired in retinal artery obstruction. It is responsible for the tunnel vision. Physiology of the macula. Primary visual direction. Oculocentric direction of any object fixed along the primary line of sight and is imagined on the center of the fovea. It consists of mainly cones. Hints play an important role in photopic vision, color vision, and the shape sense. Photopic vision neurophysiology. The steps changes in the photoreceptor occur, then processing and transmission of visual impulse in the retina. After that, processing and transmission of visual impulse in the visual pathway, analysis of the impulse in the visual cortex, then three-part system hypothesis of visual perception occur, movement, location, septal organization, color, and the shape sense. Color vision. Humans can distinguish two monochromatic lights as close as 2 mm apart, giving effective color palette of up to 300 spectral colors. It is a perceptive phenomena and subjective. There are two important theories for this color vision. One is trichromatic theory. It results from physiology of retina and not a property of light. Color vision in humans is trichromatic due to three types of cones which absorb light of different wavelengths. Opponent color theory. Some colors appear to be mutually exclusive, maybe due to subsequent neural processing beyond photoreceptors. Light adaptation. What is visual adaptation? Ability of visual system to function normally over an exceedingly wide range of illumination. Light adaptation. It is process in which retina adapts itself to bright light. My references Kurana Anatomy and Physiology. Thank you.
Good morning, everyone. Today, my topic of discussion is macular anatomical test. I'll speak about OCT and fundus fluorescent angiography. Optical coherence tomography. Cameron Poliofito described the concept of OCT in 1995 for ocular imaging. He described OCT as the first optoelectronic eye imaging system. The first prototype OCT machine was developed by a research group headed by Poliofito in collaboration with a team of physicists and mathematicians led by Dr. James Fujimoto. Later in 1996, this diagnostic technique was introduced into clinical practice. Retina is a multi-layered tissue with each layer having a different reflectance pattern. This permits recognition of its different layers. OCT is a diagnostic imaging technique that enables such recognition of a multiple retinal layers in vivo in a non-invasive manner. Advantages of the OCT. It's a rapid, easy, non-contact, non-invasive, sensitive, and highly reproducible and repeatable. OCT software facilitates qualitative and quantitative analysis, allows storage of data in memory and comparison of scans during subsequent follow-up examination. It allows detection and measurement of morphological changes in the retina, retinal thickness, retinal volume, retinal nerve fiber layer thickness, various parameters of the optic nerve head. Limitations of OCT. Difficulty in scanning in the presence of corneal edema, significant lens opacity, vitreous opacity, and hemorrhages. Exploration is limited to the posterior pole only. Optical principle of OCT. Imaging with OCT is based on Michelson's interferometer and includes complex analysis of reflections of low coherence light from the ocular tissue, low coherence interferometry. Types of OCT. Time domain OCT, frequency domain OCT. In frequency domain OCT, specially encoded frequency domain OCT, SD-OCT, and time encoded frequency domain OCT, also sept source OCT. The main advantages of the sept source OCT is a scan rate is 1 lakh per second. The OCT image can be displayed on a grayscale where more highly reflected light is brighter than less reflected light. Alternatively, it can be displayed in a color whereby different colors correspond to different degrees of reflectivity. On the OCT scanners currently available commercially, highly reflective structures are shown with bright colors like red and yellow, while those with low reflectivity are represented by darker colors, black and blue. Those with intermediate reflectivity appear green. The color codes used depict various thickness: blue 150 to 210 microns, green 210 to 270, yellow 270 to 320, orange 320 to 350, red 350 to 370, white greater than 470 microns. In the fovea, the retinal thickness ranges from 170 to 190 microns. The normal macular thickness map reveals a slight circular increase in the thickness around the fovea at the distance of about 500 microns. The scan of normal macular region appears green, while the foveal depression appears blue. The machine, OCT machine. Procedure. First, we have to inform the patient about the procedure and why it's being done. In the presence of clear media and cooperative patient, as an OCT operator can perform and acquire quality images, even with 3 mm pupil. Otherwise, dilatation is recommended. The patient is seated comfortably in the front of OCT machine with chin position on the chin rest. He is asked to fixate on the fixation target. The internal fixation target is commonly used fixation target. Those patients who are unable to fixate with macula can focus with the opposite eye on an external target. After fixation, the operator selects the desired scan and aligns this instrument so that fundus image and scan beam is displayed on the screen. Patient with significant refractive errors, rotation of the diopter compensation device may improve image quality. Some of the protocols: retina scanning protocols, line scan, raster lines, crosshair, and radial lines, X-line and circle. Macular scanning protocols: macular thickness scan, fast macular thickness, raster lines, and single line scan. Macular thickness map scan and fast macular thickness map are the two commonly used protocols. These protocols consist of a radial scan, length of 3 mm at equally spaced angular 30 degrees orientation. Retinal nerve fiber layer scanning protocols. OCT3 offers a variety of RNFL thickness measurement and analysis protocols. RNFL thickness protocol, fast RNFL thickness protocol, proportional circle, concentric 3 rings, RNFL thickness, and RNFL map. And optic nerve head scanning protocols, optic disc scan, and fast optic disc scan. Terminology is used in the case in OCT. Hyperreflectivity. seen when the structures reflect more light and appears white on grayscale, mostly due to pigments present in that layer, retinal pigment epithelium and ellipsoid zone. Ellipsoid zone is formed by mitochondria in the outer portion of inner segment of photoreceptor layers. Compact layers with horizontal arrangement of the fibers. Nerve fiber layer, outer plexiform layer, inner plexiform layer, external limiting membrane. Hyporeflectivity. When less light is reflected back, the structure appears dark on the grayscale. Shadowing. Less amount of light is transmitted through the tissue in case of drusen. Hypertransmission. More amount of light is transmitted to the tissue in case of retinal pigment epithelium defect. How to read an OCT? First, we have to see the vitreoretinal interface, and next, retinal architect, foveal contour, neurosensory retina, and retinal pigment epithelium, and choriocapillary complex. Normal retina. The posterior hyaloid may often be visible as a very faint, fine, and slightly reflective line. Internal limiting membrane is clearly defined in the OCT scans due to contrast between reflective retina and non-reflective vitreous. The nerve fiber layer that lies immediately behind the vitreous is highly reflective and more visible on the nasal side due to density of the papillomacular bundle. The four plexiform layers may be recognized as structure with reflectivity that is slightly greater than the reflectivity of the nuclear layers. The outer retina is bounded by highly reflective band that represents the retinal pigment epithelium. This band can be divided into three layers. The first is thin and hyperreflectivity, representing the junction of inner and outer photoreceptors. The second of hyperreflectivity, and third one is the thickest and most hyperreflective. The photoreceptors form a pure reflective band immediately anterior to the retinal pigment epithelium. The poor reflectivity results from vertical orientation of the photoreceptors. The Brooks membrane and the choriocapillaries are generally seen as a single less reflective structure, but in some scans, the choriocapillaries may be visible separate from the RP and the Brooks membrane. The larger retinal vessels are located indirectly by the shadow cone that they form on the posterior layers. Thus, a normal retinal architect is seen as an image with alternate zones of hyperreflectivity on the OCT. This is a picture showing recently published international nomenclature for OCT, 18 layers. First one is the posterior cortical vitreous, second pre-retinal space, third nerve fiber layer, ganglionic layer, cell layer, inner plexiform layer, inner nuclear layer, and outer plexiform layer, and Henle fiber layer and outer nuclear layer, external limiting membrane, myoid zone, ellipsoid zone, outer segments of the photoreceptors, interdigitation zone, RP or Brooks complex, choriocapillaries, and Salter's layer, halar layer, and choreo. Posterior hyaloid membrane we can see up to now. These are the layers again, choroid and RPE. Some of the few pathological conditions. In the OCT, we can see the central serous chorioretinopathy and cistern macular edema, diabetic macular edema, and macular telangiectasia, macular hole, epiretinal membrane, vitreomacular traction, and the lamellar hole, pseudo hole. Vascularized pigment epithelial detachment, CNV with edema, branch retinal arterial occlusion, retinal detachment, maculocysis, and optic disc pit. Newer technologies in OCT. Enhanced depth imaging. This involves setting the choroid next to the enhanced imaging of the choroid and the choroid scleral junction. OCT angiography. Non-invasive method of visualizing the retinal microvasculature. It does not use any dye. Based on the principle of split spectrum amplitude decoloration angiography. There is a contrast developed between the retina and the blood vessels by assessing the signal changes in the moving RBCs in the blood vessels. My references. Next, fundus angiography. fundus fluorescence angiography is a diagnostic technique that uses intravenous fluorescent dye to allow the sequential visualization of the blood flow simultaneously through retina and choroid. MacLean and Maumini were the first to use intravenous fluorescence to evaluate ocular circulation. Came into clinical use in 1961 by Nautoni and Alvis. Luminescence, a phenomenon wherein a substance absorbs visible light energy at shorter wavelength and emits longer wavelength. Fluorescence is a luminescence that is maintained only by a continuous excitation. Fluorescent dye and its properties. Sodium fluorescent, most commonly used dye, orange yellow liquid, alkaline in nature, hydrocarbon derivative with molecular weight of 376.67 kilodaltons. Biologically inert and highly soluble, 80% protein bond, 20% unbound, which is responsible for the fluorescence. Highly soluble, but it does not cross retinal vasculature endothelium and retinal pigment epithelium. Dosage. Solutions contain 500 milligrams of fluorescence are available in vials like 10 ml of 5%, 5 ml of 10%, 3 ml of 25%, given intravenously or orally when mixed with orange juice. Pharmacokinetics. Metabolized by the liver and excreted by kidney with 24 hours. Small amounts lost in bile. Skin shows yellowish tinge for few hours. Urine shows yellow-orange for 1 day. Optical properties. It absorbs the blue light with observation peaks at 465 to 490 nanometers and emits yellow-green light with a peak emission of 520 and 530 nanometers. Adverse reactions. In mild cases, nausea, vomiting, pruritus, and local tissue necrosis we can see. In moderate, urticaria, thrombophlebitis, syncope, and nerve palsy. In severe cases, bronchospasm, laryngeal edema, seizures, myocardial infarction, and rarely death may occur. Equipment: distal fundus camera and fluorescent filters. Fluorescent filters, exciter filter allow only blue light to reach the fundus. In barrier filter allows yellow-green light to captured by the fundus camera. 23 gauge scalp vein needle is used and 5 ml syringe. 23 gauge scalp vein needle is used actually and 5 ml syringe with fluorescent dye. An armrest for the fluorescent injection, tourniquet you should apply, and alcohol swab and bandage. After that, standard emergency kit to be dealt with severe adverse reactions. This is a 23 gauge scalp vein needle. Indications for FFA. Retinal vascular disorders and tumor, choroidal disorders, optic nerve disorders, integrity of blood retinal barrier, retinal pigment epithelium integrity as a guide before doing laser photocoagulation. Contraindications: in history of previous adverse reactions to dye, history of allergy, urticaria or bronchial asthma, patient with renal and liver failure, pregnant women better to avoid. Procedure: inform consent regarding procedure and adverse reactions. Dilate the pupil. Patient is made to sit comfortably with chin on the chin rest and forehead touching the head bar. This is the head bar and this is the chin rest. 3 to 4 control rate free fundus photographs are to be taken to rule out auto or pseudo fluorescent and artifact. 3 ml of 25% sodium fluorescent is injected through the antecubital vein. Arm to retinal time is normally 10 to 12 seconds. Fundus photos are taken at the frequent intervals. Circulation of the dye. Dye injected from peripheral vein. It goes into the venous circulation, enters into heart, into the arterial system, and then it enters into internal carotid artery, then into ophthalmic artery. Ophthalmic artery, from ophthalmic artery, short posterior ciliary artery, then into choroidal circulation, and central retinal artery into retinal circulation. Phases of normal angiogram: pre-arterial choroidal phase, arteriovenous phase, venous phase, early venous phase, mid-venous phase, late venous phase, late recirculation phase. Choroidal phase begins 10 to 12 seconds after injection. Early it is faint, patchy and irregular, scattered, followed by diffuse fluorescence, choroidal flush. Cilioretinal artery is present and optic disc capillaries with fill during this phase. Visualization of the choroidal fluorescence depends upon the amount of melanin in the retinal pigment epithelium cells. Arterial phase. Central retinal artery starts filling 1 second later. The choroidal filling shows retinal arterial filling and continuation of the choroidal filling. Arteriovenous capillary phase shows complete filling of shows complete filling of the arteries and capillaries with laminar flow in the veins which lines the venous wall. Venous phase. Early venous phase, filling of the veins is from the tributaries joining their margins, resulting in a tramline effect. Mid-venous phase, laminar venous flow progresses to complete venous filling. In the late venous phase, veins are filled and arteries start emptying, making them less fluorescent. Maximal perifoveal capillary filling is reached around 20 to 25 seconds. Late or recirculation phase, approximately 30 seconds after injection, the first high concentration of fluorescein begins to empty from choroidal and retinal circulation. Recirculation phase shows fluorescein in a lower concentration and it's completely absent in about 10 minutes. Fovea. Darker appearance of the fovea is due to absence of blood vessels, that is fovea avascular zone, higher amounts of xanthophyll, taller RP cells with more melanin and leftofuxin. All these factors causes blockage of choroidal fluorescence, making it appears darker. How to interpret FFA? Hyperfluorescence and hypofluorescence. Hyperfluorescence, abnormally excessive fluorescence. Case of autofluorescence, pseudofluorescence, window defect, leaking, pooling, staining. In hyperfluorescence, blockage or masking effect, vascular filling defects. Autofluorescence occurs in absence of fluorescent dye. Case of optic nerve head drusen or astrocytic hematoma. Pseudofluorescence occurs when blue light reflected from the non-fluorescent structures penetrate the green-yellow barrier filter in case of scar tissue, foreign body, and medullator nerve fiber. This we can see in the case of medullator nerve fiber. Window defect occurs due to atrophy or absence of RPE. This results in unmasking of the normal choroidal fluorescence characterized by very early hyperfluorescence that increase in intensity then fades without change in the shape of size. Is seen in age-related macular degeneration, macular hole, retinal pigment epithelium tears and defects. Macular hole we can see window defect. In RP defect. Case of dry ARMD with drusen. DNVM condition. Leaking occurs when inner blood retinal barrier is breakdown, results in hyperfluorescence, increase with time in both area and intensity. In case of diabetic retinopathy, retinal vein occlusion, cystoid macular edema. Case of branch retinal vein occlusion, leaking. Case of diabetic retinopathy. Case of cystoid macular edema. Pooling. Collection of dye in anatomical spaces due to breakdown of outer blood retinal barrier results in hyperfluorescence that increase in intensity but not in size. Case of central serous retinopathy, RP detachment. Case of central serous retinopathy. Staining. Leakage of fluorescence with retention in tissues is called staining. Late fluorescence occurs because of staining of disc, Brooks membrane and choroid and sclera. Masking blocked fluorescence effect. Kind of hyperfluorescence occurring due to optical obstruction of normal fluorescence in case of cataract condition, corneal opacity, preretinal hemorrhage, vitreous hemorrhage, subretinal hemorrhage. Subretinal hemorrhage. Case of preretinal hemorrhage. Filling defect. Kind of hyperfluorescence occurring in inadequate perfusion of tissue or loss of blood supply. Central and branch retinal artery occlusion, capillary dropout in retinopathies. Filling defects we can see in this condition. Central retinal artery occlusion, branch retinal artery occlusion, capillary dropout conditions like in case of diabetic retinopathy condition. Summary of fluorescent angiography. If it is abnormal, we have to see for hyperfluorescence and hypofluorescence. In case of hyperfluorescence, we have to see rule of auto, pseudofluorescence, leaking, pooling, staining, and window defect. In case of hypofluorescence, we have to see block defect and filling defect. my reference. First, first we have to give test dose, sir, for 0.1 ml or point. For the skin. If Take a for injecting we have to give Decadron. Emergency. Patient having any nausea, feeling, washroom should